So, good evening and a warm welcome to all the dignitaries present here. I'm Srevshi from Clirnet, serving as the allocated session assistant to ensure a seamless experience. Clirnet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clirnet serves as the digital partner for this event, hosted by the National Medicos organization. And the focus of today's session is ABC of ABG Part 1, Day 5. So let's begin today's session, for which I would like to invite Dr. Ajay sir to take over. Over to you, sir. You may proceed with the talk now.
Thank you, Shreyashi. Good evening, everyone. I am Ajay. On behalf of GSL Medical College and General Hospital Rajahmundry and National Medicos Organization Andhra Pradesh, I warmly welcome you to day 5 of our discussion series. Today's session is on ABG Part 1, focusing on the ABC of arterial blood gas analysis. We are truly honored to have with us Dr. UB Vijayalakshmi ma'am, Professor and Head, Department of Biochemistry, GSL Medical College and General Hospital, who will be guiding us to this important topic. I request all the participants to stay attentive, keep your mics muted during the talk, and kindly make use of the chat box for any queries. And we request participants to kindly raise their hand if they have any questions during the session. This will help us provide you access to unmute and interact. And today we are also honored by the presence of Dr. Pernenki Srinivasa sir, Department of Physiology, GSL Medical College, and Dr. S.V.R. Ramanamurthy sir, Professor Emeritus, GSL Medical College. I'll start the session by Dhanvantri Vandana. Thank you.
नमामि धन्वन्तरिमादिदेवम् सुरासुरैर्वन्दितपादपद्मम् लोके जरामृत्युनाशम् धातारमीशं विविधौषधीनाम्
Ma'am, we can start the session. Thank you, Shreyasi, and thank you, Team Clirnet, for this opportunity.
Thank you very much, Ajay, and thank you, Clirnet. So I hope I'm audible and the screen is visible.
Yes, ma'am.
Okay. So good evening, all of you. I'm so glad that so many of you have come forward for this session. And under the aegis of NMO, that is the National Medicos Organization, we are having this. And today's topic, it is just the basics. That's why it's been titled as the ABC of ABG. So we'll just try to see what it is. What is this ABC of arterial blood gas analysis? So let's dive right in. Now, the objectives of today's session are to know the importance of maintaining an acid-base balance. We should be able to know what is a buffer, what are the different buffering systems in the body, the mechanism of action of the buffering systems, respiratory and renal mechanisms of maintaining blood pH. So the question that comes to all of us is, why should I know about acid-base balance? For the simple reason that we are a factory which constantly is producing chemicals in the form of either acids or bases. And if these are not disposed of, then these are going to harm us. So what is it which immediately protects us from the harmful effects of these are the buffers. And as you all know, what are buffers? Buffers are those which are resistant to the action of sudden change of pH. So that is the importance of the buffer. Now you might ask me a question, how do the chemicals harm us? So this picture shows you a waterfall. Now, as you know, when you have very clean water, on either sides, there will be vegetation which grows very plentifully. But when this water becomes toxic because of effluents, then what happens to the vegetation? It gets spoiled. Similarly, if there are changes in the pH of blood or in intracellular fluids, then the proteins get denatured, their charges will change, their activity also changes. This causes also electrolyte imbalance. And as you know, Enzymes are all proteins, and enzymes cannot function because of this. So, what is our Lakshman Rekha? That is the normal blood pH. This is the normal reference range for blood pH, 7.35 to 7.45. And you have to remember this because throughout your life, you will need to know this, especially when you are in an emergency department, you're working with patients, and you suddenly see changes in the pH. Then you have to know this normal values. Now, what is the survival range of this? Now, usually what I see students mainly where they get confused is they say that the normal, that is neutral pH is 7. Anything less than 7 is acidic. Anything more than 7 is basic. But you have to realize that our blood pH is always basic. It is 7.35 to 7.45. And anything less than 7.35 is considered acidic. So that is something which you have to remember. What you have learned in your chemistry classes is anything more than 7 is basic, anything less than 7 is acidic. But when it comes to blood pH, because you see that it is blood is always alkaline. So more than 7.45 is called alkalinity or alkalosis. Less than 7.35 is called acidosis. This is something that you have to know. And the survival range, as you can see, is between 6.8 on the lower side and 8 on the upper side. And this is with regarding the arterial blood pH. Now, the next one is what are the acids which are produced intracellularly? Because we are very much worried about the acid. That is the reason why our blood is mainly alkaline. So, what are the acids which we keep producing intracellularly? We have two varieties of acids. They are called respiratory acids, which are volatile. So, how is it that respiratory acids are there? Like you have carbon dioxide, and carbon dioxide, being a gas, combines with water with the help of an enzyme called carbonic anhydrase and forms carbonic acid. And this, whenever it has to be removed, this acid has to be removed, it can only be exhaled out as carbon dioxide with the help of carbonic anhydrase. That is why carbonic acid is called a volatile acid. And where do we get carbon dioxide? We get it as the end product of either carbohydrate metabolism or fatty acid metabolism. Usually you see it in the citric acid cycle. You have carbon dioxide being released there. Many reactions in the body, you have carbon dioxide being released. So this carbon dioxide which is produced in our body, it has the ability to combine with water with the help of carbonic anhydrase and form carbonic acid. So that is the danger of this acid if it is in excess. What about metabolic acids? Now, these are called fixed acids. Why are they called fixed? This is because they are not excreted by the lungs at all. And they're usually referred by their anions. We can call them lactate instead of lactic acid. Now, the reason for this is because in the body, in that particular pH of blood, it is usually existing as an ionized state. So, lactic acid is in the form of H plus lactate ion. Phosphoric acid is in the form of H plus phosphate ion. Similarly, you have a sulfate ion for sulfuric acid. Acetoacetic acid is called acetoacetate ion. Beta hydroxybutyric acid is called beta hydroxybutyrate ion. So as you can see, you might be wondering from where are we getting this lactic acid? You know that anaerobic glycolysis produces lactic acid, and you have RBCs having anaerobic glycolysis. Then you have the exercising muscle where you have anaerobic glycolysis. Phosphoric acid is produced because you have plenty of phosphates in the body. In the form of ATP, you have phosphates which are there. And you know, in glycolysis, there are so many phosphates everywhere. So these are the cause of phosphoric acid. Sulfates are because of the sulfur containing amino acids. So that sulfur can form sulfuric acid. Acetoacetate and beta hydroxybutyrate, as you know, now they are the ones which are ketone bodies and they are the acids there. What about the diet that you take? Now, diet, you have animal proteins, they increase acid production in the body, whereas vegetable proteins increase the alkali production in the body. So you have more of alkaline urine when you have vegetable proteins. Now, the main requirement of a balanced acid-base system that you have to remember is the amount of acid which is excreted per day should be equal to the amount of acid produced per day. This is something that you have to remember. It's just like how you have the input output chart when you go to the hospital to an inpatient. How much fluid they take in, how much fluid is going out. If it is more than that, it is harmful for the body. Similarly, whatever acid is produced, that acid has to be removed from the body to maintain homeostasis. Now let us look into what are the steps of acid-base balance. Now, the steps of acid-base balance are, first thing is, this acid or the base is produced intracellularly because of the action of the metabolism. This will be buffered intracellularly. Then this is also has to be removed out of the cell, and then extracellularly again there should be buffering when it is being transported, and finally excreted by the kidneys. And here we have the Henderson-Hasselbalch equation. Now, Henderson-Hasselbalch equation here is the pH is equal to the dissociation constant of the acid, that is pKa, plus the log of the base by the acid. Here, pKa stands for the dissociation constant, which is equal to minus log of Ka. K stands for constant and A stands for the acid constant. That is, this equilibrium constant or the dissociation constant is that pH where that acid exists in a half dissociated form. That is, half of it is in the form, if we take H2CO3, half of the H2CO3 exists as H2CO3, the other half exists in a dissociated form. So that pH where half the molecules are dissociated, half the molecules are non-dissociated, now that is the pH is called the pKa of that particular acid. Now we come to the acid-base regulation. So we were hearing about ABC. Now what is this ABC? A stands for air or the respiratory regulation. B stands for the buffers, and C is the cleanser of the body, which is the kidney. So it is easy to remember this in this way because these are the three major systems which help in keeping your pH normal, your blood pH. Now let us look at the three mechanisms. So first one we have is the chemical buffer. The chemical buffers are either in the blood or they are intracellularly or interstitially they are present. They react rapidly, less than a second. Then we have the respiratory regulation. This also reacts rapidly but takes about seconds to minutes. And renal regulation reacts very slowly. It takes minutes to hours. But you all have to know that the strong one is the one which acts slowly but surely, and that is the renal regulation. The one which acts very fast and easily, it is going to be completed, that its action is very short lasting, is the chemical buffer. The intermediate one is the respiratory regulation. Now let us go into the B of ABC, which is the buffers. Now, what are the major buffers in our body? So extracellular fluid, you see that 43% is by the bicarbonate and the protein buffers. Majorly, remember, it is the bicarbonate buffer. And when I say buffer, you should know that it is made up of carbonic acid, which is the acid, and bicarbonate, which is the base. And we also have proteins because they are present both interstitially in the interstitial fluid as well as within the cell. Then we have the intracellular fluid. In intracellular fluid, we see that majorly we have the phosphate buffer. We also have the protein buffer and the bicarbonate buffer. So you may be wondering, proteins are present quite abundantly both intracellularly and extracellularly. But you have to remember, we are not talking about that which is major. We are mainly talking about that which is efficient. And the efficient one extracellularly is the bicarbonate buffer. Efficient intracellular buffer is the phosphate buffer. We also have the sodium proton exchange and the potassium proton exchange, which takes place in the kidney. Now coming to the first buffer, extracellular efficient buffer, which is the bicarbonate and carbonic acid. So you can see you have the base, you also have the acid. Now this is the body's major extracellular buffer, and it is having the carbonic acid, which is the acid, and we have the bicarbonate, which is the base. What about the alkali reserve? The alkali reserve is the ratio between the base to the acid. So you can see here that the base is about 24 milliequivalents per liter, which is bicarbonate, that is the mean value. And the acid, which is about 1.2 milliequivalents per liter, the mean of the carbonic acid. Now that ratio will be about 20:1. So remember this, that the alkali reserve is 20:1. So you can see how efficient it is. It has so much of alkali, and it's able to resist the sudden change in pH caused due to the acid. And that is how it maintains a pH of 7.4. Now coming to the regulation. So we have already seen that carbon dioxide and water, the reaction is with the help of carbonic anhydrase, an enzyme, and you have the formation of an acid called carbonic acid. This is ionized to form a proton and a bicarbonate, which is the base. So there is always a dynamic equilibrium. There is a shift to the right or the left depending upon the need. So that means you have a shift either towards the base, bicarbonate, or towards the acid, which is the carbonic acid. And it all depends upon what is entering into the blood. Is it the base or is it an acid? And then it tries to maintain the pH by either removing the acid in the form of carbon dioxide, if it is a volatile acid, and and also by if it is going to remove if it is excess of base, it will try to remove it in the form of bicarbonate. It excretes it through the kidney. So this is what happens to it. This is what is the importance of dynamic equilibrium. When we say dynamic equilibrium, you should understand that homeostasis is maintained only because it is dynamic. If you it could be either glucose or calcium or any of the analytes that you take, how is it that they are maintaining that reference range? This is because there is a constant dynamic reaction that is going on within the body. Now that is about the extracellular buffer, which was the bicarbonate buffer. Now the most efficient intracellular buffer, we said, was the phosphate buffer. Now phosphate buffer, the pKa of the phosphate buffer is about 6.8. Now for the phosphate buffer, you can see that the acid form of that is in the form of H2PO4. It is able to donate a H plus ion. And the base form of that is HPO4. It is able to accept a proton. And because its pKa is around 6.8, and it is very effective as a buffer, +1 or -1 at a range of pH which could be +1 or -1. So therefore, the acid environment within the cell, it acts as a very good buffer. Whereas bicarbonate, its pKa is around 6.1. The alkali reserve of a phosphate buffer is about 4. Then we come to the protein buffers, which are present majorly in the body. It includes hemoglobins, different proteins. They work in the blood as well as in the interstitial fluid. You have to remember that a protein is made up of number of amino acids, and you have the carboxyl group, it gives up a proton. Amino group can accept a proton. So therefore, a carboxyl group acts as an acid, the amino group acts as a base. You also have many side chains of amino acids that can buffer the proton. They are present on the different amino acids. Histidine is very important here because it has a side chain which is having an imidazole ring, and its pKa is around 6.1. And we have hemoglobin, which has plenty of histidine within it. Similarly, albumin also has plenty of histidine. Therefore, the histidine acts as a very good buffering system, both as an acid as well as a base. So that is with relation to the chemical buffers. So chemical buffers, we have seen that we have the 3 major buffers. We have seen that you have a bicarbonate buffer, which is an efficient extracellular buffer. We have seen the phosphate buffer, which is an efficient intracellular buffer. And we have also seen the protein buffer and its side chains, which help in maintaining the buffering capacity. Any questions till now, which you can put in the chat box? Okay.
Correct.
So if you have any questions, you can put it into the chat box. Now we'll go to the second level, that is the respiratory regulation. Remember, the B was for buffer, right? So we have finished the chemical buffers now. Now the A of the ABC is for air or the respiratory regulation. Now let us look at what actually happens in respiratory regulation. Now, respiratory regulation, you have to remember that it is mainly related to the RBCs and the hemoglobin. Now, at the level of the tissues, you have a lot of production of carbon dioxide because they have a lot of metabolism taking place, carbon dioxide being released. a lot of carbon dioxide is now entering into the system. Now, let us look at this animation which talks to us about what happens to the carbon dioxide which is being released from the tissues. Now, they enter into the RBC and they are going to react with the water that is present in the RBC with the help of our enzyme, which is carbonic anhydrase. Now, then you have the formation of carbonic acid, which is immediately hydrolyzed to form or ionized to form H plus and HCO3. And you can see the chloride shift here, where bicarbonate goes out, chloride enters in. This is called the chloride shift and leads to the Hamburg phenomenon. The H plus which is there now, it is quite harmful because it is changing the pH. So it should be buffered, and it is buffered by the hemoglobin. And we all know that hemoglobin is rich in histidine, which has the imidazole group, and it is able to buffer the H plus ion. So this is happening at the level of the tissues. Now let us look at what happens at the alveolus. Now, when it comes to the alveolus, the reverse happens. The bicarbonate enters in, the chloride goes out. The H plus, which was there now, it binds to the HCO3, and you have H2CO3, which is acted upon by carbonic anhydrase to release carbon dioxide and water. Carbon dioxide goes out, is exhaled, and water remains within. Now, the question that you should be asking is, how is it H plus has become free now? It was always bound to hemoglobin, and how is it miraculously it has become free? Now, the reason for this is at the level of the alveolus, you have a lot of oxygen entering into the system. Now, oxygen is able to displace this H plus ion. So, when it is displacing that, H plus ion is now bound to HCO3, and that is how you have the formation of H2CO3, and which is again converted by carbonic anhydrase into carbon dioxide and water. Okay. Thank you, sir. So this is about the bicarbonate at the level of the alveolus. Now, next we'll go on to the sources of the hydrogen ions. From where are we getting these hydrogen ions which are harmful? So the first thing, as you all know, cell metabolism, where you know in the TCA cycle how carbon dioxide is produced. Then we have the food products, the foods that we daily eat. So with them, synthetic products, they can produce a lot of hydrogen ions. Medications that we take, they, during their metabolism, they can produce hydrogen ions. Metabolic intermediate byproducts you have, like you can have lactic acid, you can have the formation of sulfuric acid, etc., which are formed in the body. Pyruvic acid, disease processes. When we have diabetic ketoacidosis, the keto acids which are formed, starvation can form ketone bodies. Similarly, you have methanol poisoning. They can give rise to acids which are formed. Ethanol poisoning can give rise to acids. So these are the different ways by which we can get hydrogen ions can enter into the system, decreasing the pH of the blood. Now let us look at the bicarbonate ions. What are the sources of bicarbonate ions? Now, one you have already seen in the previous slide, carbon dioxide when it enters into the RBC. Now, it is converted into carbonic acid that is getting ionized to form H plus and bicarbonate, and that is how you get bicarbonate within the cell. Another source is the parietal cell secretion of the gastric mucosa. Now, an interesting thing that you have to remember here is whenever a H plus ion is secreted into the stomach, there is also a bicarbonate which is entering into the blood. So therefore, the bicarbonate is coming from this source also. So this is another point for you to remember. These are the sources of bicarbonate ions. Now coming back to our equation, the pH is equal to 6.1. So this is related to the bicarbonate buffer. So the carbonic acid, the pKa is 6.1 plus log of the base, which is bicarbonate, by the acid. Now, how do you get H2CO3? This is the formula. 0.03 is the solubility coefficient of carbon dioxide. And PCO2 stands for the partial pressure of carbon dioxide. So partial pressure of carbon dioxide in the arterial blood, they have found that you can take it as a mean of 40 millimeters of mercury. And this multiplied by that into 0.03, you get a value of 1.2. And bicarbonate, we have already seen the mean value is around 24 millimoles per liter. And that is how we get a pH of 7.4 when we do this log of 20. So now these are the dark arrows that you can see. You have to remember these two. The bicarbonate that you can see here, that is the one which usually undergoes changes whenever there are metabolic disturbances. So primary change whenever there is metabolic disturbances will be seen in the bicarbonate. The dotted arrow is telling you about the secondary changes. Secondary changes in the bicarbonate happens whenever it is renal is compensating for the respiratory disturbance that happens. Now, similarly, you can look at the carbon dioxide, the partial pressure of carbon dioxide, whenever there is a primary change in the respiratory, that is, there is a problem in the respiratory system, then you have a change in the PCO2. And this PCO2, the dotted arrow, is telling you it will change secondary to a metabolic disturbance. The PCO2 is secondary changing in metabolic disturbances. So these 2 points you have to remember. Whenever we use the term metabolic, remember that something has happened to the bicarbonate. Whenever you are using the term respiratory, you have to remember something is happening to the carbon dioxide. So this will give you a main idea. And the dotted lines are telling you secondary changes that happen. Now coming to, so we have completed now the blood, that is the buffers. You have completed the B, we have completed. We have completed the A, that is the respiratory or the air. Now we come to the C of the ABC, the cleanser in the body, which is the renal regulation. Okay. So, so any questions till now? So any questions, you please put it in the chat box so that it will be answered. So we come to the renal regulation. So we have completed the chemical buffering system, we have completed the respiratory, and you've seen that at the level of the tissues, what is happening, at the level of the lungs, what is happening. We have seen the chloride shift that has taken place. And now we come to the renal system. Now this is a very important, it plays a very important role. You can say that this is like a mighty army which is present in our body. And if this line of defense also fails, then what is going to happen? The fort, which is our body, is also going to get destroyed. So that is why this is a very important regulatory system in our body. Now let us see, what does the kidney do? Now the kidney has the ability to reabsorb the bicarbonate. That is why it is maintaining that alkalinity in the blood. It has the ability to reabsorb bicarbonate. Now in this diagram, you can see that we have the lumen here, the tubular lumen. We have the tubule, cell of the tubule, the proximal convoluted tubule, and we also have the blood on this side. Now, in the lumen, we have the bicarbonate, which is filtered along with sodium. So you have sodium bicarbonate, which is being filtered. Now, as it is being filtered, the sodium and enters into the cell, and the proton or H plus ion goes out. This is the antiport which is acting here in the tubular cell. The sodium enters into the cell, the proton goes out. Now, this proton reacts with the bicarbonate and forms carbonic acid. Carbonic acid is acted upon by carbonic anhydrase, which is present in the tubular epithelial cells at the brush border. It is present. So here, this carbonic anhydrase converts the H2CO3 or the carbonic acid into water and carbon dioxide. Carbon dioxide, being a gas, is easily diffusible and enters into the cell. Water also enters into the cell through aquaporins. So it enters into the cell, and here again we have carbonic anhydrase, which convert these two into carbonic acid. Carbonic acid is immediately ionized to give rise to a proton and bicarbonate. Bicarbonate goes out into the blood. So that is how it is entering into the blood. What about the sodium which has entered? We know that every cell has a sodium potassium pump, and therefore sodium goes out and potassium comes in to the cell. So this is happening at the level of the proximal convoluted tubule. This is the bicarbonate reabsorption that is happening. Now let us look at what about new bicarbonate which is forming and the loss of the H plus ions or the acid. Now let's look at this diagram. Now in this diagram, we can see here that this is called the phosphate buffer, which we have heard of. Now phosphate buffer is also present extracellularly, though the quantity is less when compared intracellularly. So extracellularly, whatever phosphate buffer was there, it has got filtered and it has entered into the tubular lumen. Now, once it has entered into the tubular lumen, you can see, and it is usually associated with sodium, which has not been shown here. So remember the same thing as in the previous slide, sodium enters into the cell. Okay? That is what you have to remember. And H plus ion comes out of the cell. That is what you can remember. So here, which the phosphate which is there, it is in the form of a base. So it is accepting the H plus ion which is there and forming the acid form, which is sodium dihydrogen phosphate. Why I'm saying sodium is the base which was there was disodium hydrogen phosphate. One sodium has already entered inside. The other sodium was not able to enter inside. The other sodium remains. Now it accepts this H plus ion and it forms sodium dihydrogen phosphate. So it forms sodium dihydrogen phosphate, which is excreted. Now here you can see that this proton is being pumped out. Now, how did this proton come? That is the question. Now, in every cell, you know that these metabolic reactions are happening and carbon dioxide is formed in every cell. Now, this carbon dioxide which is formed, it is reacting with water, again in the presence of carbonic anhydrase, forming carbonic acid. This carbonic acid is again getting ionized to give rise to a proton and bicarbonate. So here you have to remember a new bicarbonate and a new proton. It is not something which was reabsorbed. This is something which is forming freshly. So in this way, the acid in the form of H plus ion is being removed from the cell actively by means of a pump, and it is sent out into the lumen where it reacts with the base of the phosphate buffer and it is excreted in the form of the acid. This acidity or the phosphate buffer is called titrable acidity. You might get a question on titrable acidity. So titrable acidity is mainly by the phosphate buffer. And where is this taking place? It is taking place in the distal convoluted tubule, the collecting duct. So these are called acid secreting cells, they are called. So this is about the uh, phosphate buffer. Now let us look at the most important critical buffering system, which is the ammonia and the ammonium ion which is formed. Now the ammonia is formed through this reaction as you can see here. Now glutamine is a non-essential amino acid. Now glutamine is hydrolyzed by an enzyme called glutaminase to release ammonia and glutamate, which is another amino acid. Now, ammonia being a gas can easily leave the cell. So it is permeable, the cell membrane is permeable to it, it goes out of the cell. There, it binds to the H plus ion, which is being produced by the distal convoluted tubule, by the collecting duct, which is being produced. It binds to that and forms an ammonium ion. Now, ammonium ion, it is not dissolvable in the cell membrane. So it is easily excreted. Now, what you have to remember here is this glutaminase reaction, which is being shown here, it is actually happening in the proximal convoluted tubule. It is shown here so that it is easy to understand from where this ammonia has come. Now, the ammonia has come through this reaction that is taking place in the proximal convoluted tubule. Now, this ammonia, because it is freely permeable, it enters into the lumen, reacts with the H plus ion, and ammonium is formed. Now, the cell membrane is impermeable to ammonium ion. Therefore, ammonium ion is excreted as such. This is something that you must remember, that these are the two major urinary buffers. One is the phosphate buffer, one is the ammonium buffer. And out of these two, the one which is more effective in reducing the acidosis in the body is the ammonium buffer. So this is the most important buffer, which is the ammonium buffer. So I hope this is clear to you now, the renal regulation. So we have what we have seen here. We have the previously the reabsorption of the bicarbonate, which you've seen. Then we have the formation of new bicarbonate with the loss of H plus ion. And finally, we have seen that through the urinary buffers, the phosphate buffer and the ammonium buffer, we have the removal of the H plus or the acid which is present. So any other questions that you have to pose before I ask you questions? Okay. The questions which we have got here is, how do we identify mixed acid-base disorders in ABG interpretation? Very good. We'll come to that. But first, let us understand the basics. We will do that in part 2 that will come tomorrow. So right now, let us try to understand the basics. And once we understand the basics, from here, we'll go on to the next one, which is going to be the uh, how do we recognize these acid-base disorders. Okay, so are you ready for answering these questions? So let us see how far we are on the same page. What are the three important regulatory systems of blood pH? Can you just put it in the chat box? Excellent. Yes, chemical buffers regulate first, right? You have the chemical buffers, you have the renal and the respiratory. Yeah, excellent. Then we come to the next question. Most efficient extracellular buffer. Which one do you think is the most efficient extracellular buffer? Most efficient bicarbonate. Very good. Most efficient intracellular. Most efficient intracellular. Excellent. Phosphate buffer. Most efficient intracellular. What about the alkali reserve of the bicarbonate and phosphate buffers? Can you tell me the alkali reserve of the bicarbonate and the phosphate buffer? Right. 20:1 and 4:1. Excellent. Then we have the major urinary buffers. Can you tell me about the major urinary buffers? Very good. Phosphate is one, and the other one is ammonium. Right, excellent. Then we have, what is titrable acidity? Which one is called titrable acidity? Phosphate is called titrable acidity. Excellent. Urinary buffer that plays a critical role in acid-base balance. Urinary buffer which plays a critical role, most important urinary buffer out of the two, phosphate and ammonia, which is the most excellent, ammonia. Excellent. So now that you've got an idea about this, let us go into the second part of this. Right. So now that you got some idea about the basic, we'll go into acid-base imbalances. So you have to understand some terms. One is called compensation. Compensation means the corrective response of kidneys and or lungs. Compensated means restoration of the pH back to normal, that is between 7.35 and 7.45, and the ratio of the bicarbonate buffer should come back to 20:1. When is it called uncompensated? When the pH you're not able to adjust, that is, it is still abnormal, either acidosis or alkalosis, and the ratio is also not adjusting. It is not the usual 20:1. So this is called uncompensated. You have to remember these words because later on there will be questions on uncompensated metabolic acidosis, compensated, fully compensated, partially compensated. You should be able to understand the terms. When it is uncompensated, the pH is abnormal, the ratio is abnormal. Compensated, pH is normal and ratio has also come back to normal. And the compensation is by what? Either by the kidneys or by the lungs. Right. Now, what are the four basic types of imbalances? We have respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis. Now, let us look at respiratory acidosis. What is respiratory acidosis? Here, carbonic acid, we have said carbonic acid is a volatile acid. Now, this carbonic acid is present in excess. What is the reason for that? Because exhalation of carbon dioxide is inhibited. Now, carbonic acid is now building up. So, whenever acid is building up, we say that the pH is now falling to less than 7.35. Why is the acid building up? Carbonic acid, why is it building up? Because exhalation is inhibited. Exhalation of carbon dioxide is inhibited. So, the cause is hypoventilation. So as you can see here, carbonic acid is increasing now. Now, there are several causes, as you can see. You have acute causes and chronic causes. A simple thing to remember here is whenever the respiratory center is affected, whenever there is hypoventilation, whatever be the cause. So, it could be either sedative overdose, it could be cardiac arrest when there is no breathing. You remember that no breathing, no pulse, no consciousness. So, that's why. So, not responsive, which you learnt in CPR. Then you have pneumothorax, pulmonary edema. All these things are affecting somewhere the lungs. Similarly, in chronic obstructive pulmonary disease, brain tumors, respiratory nerve damage, myopathies, which are affecting the respiratory muscles, any of these things will prevent the exhalation of carbon dioxide. Lungs are unable to function properly. So let us look at what is going to happen now. So you can see here that the bicarbonate is still normal, but carbonic acid is building up. So what happens to the ratio? Now the ratio has become less. So the ratio has become 13 is to 1. It should have been 20 is to 1, the bicarbonate buffer ratio. It is alkali reserve has come down to 13 is to 1. What has happened to the pH? It has come down to 7.2. So this is because the volatile acid is increased. It is not being exhaled out. Therefore, the concentration of the carbonic acid has come to 1.84. This is what has happened. Now let us look at the compensation. How is the body going to compensate? If you remember our previous Henderson-Hasselbalch's equation, whenever there is a respiratory problem, we said whenever that is affected, we said the kidney is going to now take part and try to compensate. So what does the kidney do? The opposite regulation, which is depressed breathing when it is leading to a buildup of carbon dioxide, the response is by the kidney. Now the kidney is going to try and retain bicarbonate. What is the purpose of retaining bicarbonate? So that the ratio can come back to normal. But the response is slow. As you know, it might take hours to days, it might take. So this is about the respiratory acidosis. Okay. So respiratory acidosis, simple thing for you to remember, look at always the carbon dioxide. If it is very high, then you know that, yes, this is because of volatile acid is not being sent out of the body. That is the reason, and you know all the causes because of which the volatile acid, that is carbonic acid, is not sent out. What will be the compensatory mechanism for that? It will be the kidney's action. The bicarbonate is going to be reabsorbed a lot. What is the purpose of doing that? So that the ratio comes back to 20 is to 1. So that is the purpose of trying to reabsorb more and more bicarbonate. This is about respiratory acidosis. Now let us look at respiratory alkalosis. It is the exact opposite of respiratory acidosis. Here you have a carbonic acid deficit. What is the reason for that? There is increased exhaling of carbon dioxide. So carbon dioxide is lost. So there's a very fast, there is hyperventilation is happening here. So what is the cause of that? So many reasons are there. We'll come to that. Carbonic acid level comes down. pH now rises above 7.45 and the cause of hyperventilation. So you can see here when carbonic acid is decreased, bicarbonate remaining the same, look at what has happened to the ratio. Now the ratio has now changed. So the ratio has become 40 is to 1 and what has happened to the pH? It has become alkalosis now. Previously it was acidosis. Now it has become alkalosis. It has become 7.7 now. So the ratio which should have been 20 is to 1 has now changed to 40 is to 1 and there is alkalosis. This is respiratory alkalosis. Now what are the different causes? For you to remember any cause of hyperventilation. You have anxiety, hysteria, students before an exam, before or performance on the stage for some reason, when you have hyperventilation, hysterical causes, fever, when you have high grade fever. There is also another thing where you have salicylate intoxication. Now, one student was asking about mixed acid base. Now, this is a condition where you can have a mixed acid base, where you have salicylate intoxication can not only cause respiratory alkalosis, it can also cause metabolic acidosis. You can have a mixed acid base disorder here. Okay. Then there are so many causes as you can see. So all these are the causes which can cause hyperventilation, and hyperventilation leads to a loss of all the carbon dioxide, and that is going to change the ratio that is between the carbonic acid and the bicarbonate, and therefore there will be alkalosis. Now, how does the body compensate for that? We know that whenever there is a problem in respiratory, it is the kidney which comes play. So the kidney will start excreting more and more bicarbonate. And you can see that the acid secretion is also getting reduced. Titrable acidity. We said that the phosphate buffer is the one responsible for titrable acidity. That gets reduced to show that the H plus ion is being conserved in the body. So that is why the titrable acidity is reduced here. This is the compensation. So respiratory acidosis, respiratory alkalosis. Respiratory acidosis, PCO2 was high. When I say PCO2, remember it is partial pressure. So partial pressure, if it is written as PaCO2, remember it is partial pressure in the arteries. So PaCO2 is a partial pressure in the arteries of carbon dioxide. PCO2 is just partial pressure of carbon dioxide. And for convenience, we write it as PCO2. So you look at PCO2. If it is high, no, it is respiratory acidosis. If it is low, no, it is respiratory alkalosis. And when I'm talking about this, I'm talking about a simple respiratory acidosis, simple respiratory alkalosis. Okay. Now we go on to the metabolic acidosis. Now, metabolic, whenever we use the term metabolic, we have to remember that here it is first either the chemical buffer, which is the one which has got involved more. So something is happening at the level of the chemical buffers or the bicarbonate. That is what you have to remember. So the base, that is bicarbonate, there is a deficit in that. That is led to the metabolic acidosis. So what will happen here? The pH is again low, less than 7.35. Low plasma bicarbonate, that is the base. It could also be because of a gain in H plus ion, like we see in lactic acidosis, ketoacidosis, etc. So remember, there are two reasons for metabolic acidosis. Either the plasma bicarbonate is low, or there is a gain in the H plus ion because of lactic acidosis or ketoacidosis. So gain in H plus ion is because of these two reasons. Loss of bicarbonate could be because of renal failure, could be because of diarrhea. So let us look at what happens in this. Now, in this, whenever you have a renal failure or a kidney failure, there is a decrease in bicarbonate because the reabsorption is not happening. So reabsorption, which we saw at the renal regulation, we saw that there should be reabsorption. 80% of the bicarbonate is being reabsorbed in the proximal convoluted tubule. Now, this does not happen. When this does not happen, what's going to happen now? Look at the carbonic acid and the bicarbonate. Carbonic acid level is coming down. Carbonic acid remains the same. What is happening to the ratio now? So the ratio, as you can see, has come down. And because of which the pH has also come down. So this has happened at the level of kidney failure, leading to metabolic acidosis. Okay. So this is metabolic acidosis because of kidney failure. Now we'll go to the reason where you have metabolic acidosis because of excess of acid being produced by the body. Like we see in lactic acidosis or ketoacidosis, there is an increase in acid. There is no change in bicarbonate, but acid is increased. So again, now the ratio is going to change. So the ratio is again going to become lesser, and the pH is also going to fall because of that. So I hope this gives you a clarity on metabolic acidosis. There are two causes. Either bicarbonate is being lost, like example is either you have diarrhea, you have kidney failure, or it could be that excess acid is being added, like we have in lactic acidosis or ketoacidosis. Now, another common term that you will come across is anion gap. Now, what do we mean by anion gap? Now, anion gap is the unmeasured anions which are present in the blood. So you know that we have cations and we have anions. So the cations that we have are, as you can see in this picture, we have sodium and potassium. They are the major cations present in the blood. The major anions which can be measured are chloride and bicarbonate. So normally you can see that when you have sodium and potassium, supposing we take sodium to be around 140 millicoulomb per liter, Potassium, we think the concentration will be around roughly 5 milliequivalents per liter. It will be around 145 will be the uh, sodium plus potassium, that is the cations, the measurable cations. When you look at chloride, suppose we take roughly it is around 105 milliequivalents per liter, bicarbonate, which is roughly around 125 milliequivalents per liter, and you minus the cations from the anions. Here we have got an anion gap of 15. The normal is around 8 to 18 millimoles or milliequivalents per liter. So this is the normal anion gap. What is this gap telling you? We know that usually whatever, how much ever sodium cations are there, so much of anions should be present. But there are some anions which we are not able to measure. They are usually in the form, as we have said previously, lactate, sulfates, phosphates, etc., and proteins which are there in the anionic form. So these are the ones which are not being measured. So normally they constitute very less, around 8 to 18 millimoles per liter. But there are some conditions where you can have a high anion gap, and there are some conditions where you can have a normal anion gap. So let us look at conditions where you have a high anion gap. What do we mean by a high anion gap? In a high anion gap, what is happening here is bicarbonate is coming down, chloride remains normal. So overall, the anions are becoming less, which are being measured, whereas the cations remain the same. So the difference in the two is now almost 25. So 25 is the value of the unmeasured anions. So what could these anions be? That means something has been added, some acids are being added which are using up the bicarbonate. So that could be either lactate, pyruvate, etc. Or it could also be the ketoacidosis that could be causing the keto acids, which could be adding to this. So this is the reason why the anion gap is increasing in these conditions. There is another anion gap which is called a normal anion gap, as you can see here. Now this normal anion gap, you can see, though the bicarbonate is less, still you can see here that the chloride is being increased. So the chloride is being increased, because of which it is still maintaining a normal anion gap of 15. So that is why this is called normal anion gap metabolic acidosis. So you have two types, a high anion gap metabolic acidosis or HAGMA, normal anion gap metabolic acidosis or NAGMA. Let us look into them. Now, this is an acronym so that for you it will be easy to remember the causes of high anion gap metabolic acidosis. KULT, cult. So that is K for ketoacidosis. Whenever keto acids are being added, it could be either diabetic ketoacidosis, starvation ketoacidosis, alcoholic acidosis, where it is mainly lactate. Then we have also U for uremia, that means renal failure, L for lactic acidosis, E for toxins, like it could be methanol, aspirin, or metformin overdose, ethylene glycol. So these are the toxins which can lead to high anion gap metabolic acidosis. Then we have normal anion gap. So here is another mnemonic for you to remember, that is hard up. Hard up stands for H for hyperalimentation, A for acetazolamide use. Acetazolamide is something which inhibits the action of carbonic anhydrase. R for renal tubular acidosis, D for diarrhea, U for ureter sigmoid fistula, because of which bicarbonate is being lost, P for pancreatic duodenal fistula, again bicarbonate is being lost. So whenever bicarbonate is being lost, you have to remember the body is trying to conserve chloride. That is the reason the anion gap still remains the same. So these are all the causes of normal anion gap and high anion gap. Okay. So this is about the metabolic acidosis. Now let us look at the compensation. We know that either it could be low bicarbonate or high H plus ion, which is leading the problem of metabolic acidosis. Now what is the response of the body? This should be by the lungs. Now the lungs, we always said whenever the problem is with bicarbonate, then immediately the lungs come into action. So the volatile acids it will try to remove. So lungs hyperventilate, get rid of carbon dioxide, and therefore there'll be a decrease in the partial pressure of carbon dioxide in the arteries, and therefore there will be a rise in the level of the bicarbonate. So as it keeps on removing that, it brings the bicarbonate back, that is the ratio comes back to normal. This is about metabolic acidosis. So remember, in diabetic ketoacidosis, if you remember the patient of diabetic ketoacidosis, there will be a respiration which is called Kussmaul's breathing. So Kussmaul's breathing is a condition where there is hyperventilation because the body is already trying to deal with this excess acid by removing the volatile acid, which is carbonic acid, by removing the carbon dioxide from the body. By doing that, it is trying to bring the ratio of the base to the acid as 20:1. And when it tries to bring the base and acid is 20:1, the pH will come back to normal. So that is about metabolic acidosis. Now next, let us go into metabolic alkalosis. Now metabolic alkalosis here, as the name suggests, there is a bicarbonate excess. pH is more than 7.45. There is either a loss of H plus ion or there is a gain of bicarbonate. What are the common causes? The common causes are vomiting. So when there is vomiting, what is happening? The HCl which is present is being lost. So H plus ion is lost, the acid is lost. And we already said that whenever a H plus is being sent into the lumen of the stomach, there is a bicarbonate entering into the blood. So the more and more H plus is lost, more and more bicarbonate is being entering into the blood. So therefore you have more and more bicarbonate there. Then you have gastric suctioning, that is nasogastric suction. So patients who are unable to feed themselves, who are admitted in the inpatients, there is nasogastric suction that is being done. So acid is being removed. In them also you should always monitor for metabolic alkalosis. The other causes could be abuse of antacids. So people who have problem acidity, etc., they keep taking plenty of antacids orally. So they have carbonates in them, or they can be having lactate in them, which is finally converted into carbonates. Now these carbonates, they have the ability to increase the bicarbonate or the base. Similarly, potassium wasting diuretics. When potassium is being lost in the body, you have to, what the body tries to do when there is hypokalemia is it tries to send the potassium within the cell to outside the cell. And in turn, it takes the H plus ion present outside the cell inside the cell. In that way, again, it can create a bicarbonate excess in the body. So these are the causes of metabolic alkalosis. So in metabolic alkalosis, as we can see, the bicarbonate value rises, carbonic acid remains the same, but what happens to the ratio? The ratio has got altered, so it is more of a basic pH that we have in the blood. Now, what is the compensation? The previously, when it was metabolic acidosis, the compensation was by hyperventilation. Here, the compensation should be by hypoventilation. It tries to retain the carbon dioxide, increases the partial pressure of carbon dioxide in the arteries, increases the acid level, trying to bring back the ratio to normal. And that's how it tries to bring the pH back to normal. This is the compensation. And I was talking to you about so this is about respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. And these are the electrolyte shifts, as you can see. So the electrolyte shifts that you have to remember mainly related to H plus ion. You have to remember this in acidosis, always the H plus ion, when there is acidosis, the body tries to remove the H plus ion, puts it inside the cell. And in turn, it puts potassium out of the cell. Therefore, you have hyperkalemia. Similarly, in alkalosis, what happens is it removes the H plus ion which is present within the cell. It removes it out. It takes potassium into the cell. And that is how it tries to deal with the alkali that is present. So this is what you have to remember about hypokalemia and hyperkalemia. So hyperkalemia is associated with acidosis. Hypokalemia is associated with alkalosis. Okay, so we will go to simple acid-base disturbances later on. I think we'll keep around 15 minutes for any QA that you might have. This we'll do it in the next session. So So anything that you want to put into the chat box or anything that you want to raise your hands?
I request participants to use the chat box for any questions.
Shall I stop screen sharing, Ajay?
Yes, ma'am, no problem, ma'am. You can share or you can.
Okay, I'll stop it then. Okay.
Okay, ma'am. Thank you.
Yeah. Good evening, sir. Ramnamurthy, sir.
This is Dr. Ramanamurthy.
Yes, sir. Good evening, sir.
Very nice to hear your speech, madam.
Thank you, sir.
Many points I learned from your speech.
Oh,
There
thank you very much, sir.
explanations which are to be clarified or which are clear for certain individuals. Actually, in acid-base circulation, we know what is happening, but you told how, why, when. So very lucid presentation. Thank you, madam.
Thank you very much, sir. So this is very basic, sir. This is mainly I'm keeping in mind the first year students because
Yes,
they're going
madam.
for their exam. So I thought
Yes, ma'am.
that if I explain these basics and tomorrow we'll have the acid-base disorders, then case presentations so that they'll also get an idea about, usually they get these questions in the exams. It might be an essay question or they might get it as a 5 marks question. And it also
Yes,
helps
madam.
when they go into the phase 2 and phase 3 when they have to really see a patient. So these concepts, if I'm sure I'm telling very basics, you must be knowing more than that, sir, because you have seen and dealt with patients.
You know, little, madam.
So thank you very much, sir. So, yeah. Oh, helpful for final years also. Okay, that's great to know. Oh, okay, then. So if there are no questions, so shall we stop here then? PPT, I will share it to Ajay and he will put it in the group. And we'll have the PPT, final PPT, that is even after tomorrow's class. Then I'll give it to Ajay. So feel free to share your questions because the more as they always say, and as I've seen Dr. Ramanamurthy also, he is a perpetual student. They say good teachers are perpetual students. So actually from students we learn more because you ask more questions that will make us think more, that will make us delve into the
Ma'am,
subject more. So that's a good thing. Yeah.
ma'am, a student is asking a question, ma'am. What is the use of calculating the anion gap?
Anion gap we want to calculate to see whether, because we have to see what is the reason why so much of acid has been added. You want to know the unmeasured anions, right? And you also want to know how do we correct that? So that correction, and for unmeasured anions, if you know that, okay, the gap is so much, I have to fill the gap. For that, again, you have to look at base excess. Whether the base excess is -2 or +2, that is also another thing you have to look at. So how much should I add the base? How much should I add? This is something that you have to know. That is why you do that. Dr. Amnamurthy, would you like to add some more points to this? Why do we have to calculate the anion gap?
For metabolic acidosis, we have to decide or divide all the cases into normal anion gap metabolic acidosis or high anion gap acidosis or low anion gap metabolic acidosis. So for the treatment purpose, we must know. Of course, we have already told how anion gap is given. Generally, around 12 to 16 milliequivalents will be normal. So depending on the cause, we decide whether it is high or low.
It's only to treat. For treatment purpose, you have to know the
For
anion.
the treatment purpose, it is definitely used.
Yes, yes. So that is okay. And again, there is a change that you have to do when you come to know that albumin is low. Again, there is a correction factor that has to be added to the anion gap. These are little higher concepts actually. So I'm not dealing with the higher concepts. So we are just doing the very basics we are doing. Okay, we'll have
Madam,
another session. Yes, sir.
if I am allowed, I would like to talk on ABG. Of course, at a later time, if the SO organization.
Definitely, sir. Definitely, sir, because I think it will be very useful for the final years also. So I think they
But
need
the
to
only
know
thing is,
ABG. Yes, sir.
I shall take it up only after September 6th. I'll
Yes,
be
sir.
away from Bengaluru to Kakinada, that is Rajahmundry,
Right,
right
sir.
from 20th to September 6th.
Okay, sir.
After
So,
6th, I shall be ready.
okay, sir.
On whichever date you decide, the
Yes, sir.
organization, I shall be ready.
Yes.
And platform also, we shall increase.
Yes,
Audience
yes.
shall increase.
Yes, sir. We can do that. Definitely, we can do that.
Thank you, madam.
Thank you, sir.
Ma'am, another student is asking why is it important to correlate ABG findings with electrolytes like sodium, potassium, and chlorine?
Yeah. So you have, as you have seen, no, that whenever there is a change in the acidosis or alkalosis, you have seen there is a potassium shift. What will happen if you have hypokalemia? You know what are the dangers which can happen to the heart. Hyperkalemia, you know what are the dangers that can happen to the heart. Similarly for sodium also. When you have hypernatremia, what can happen? Hyponatremia. So the muscles can also be affected. So the heart muscle, skeletal muscle, etc. That is why we have to know about this. That is why we have to see that. So you should know even those values also. The ABG instrument also gives you the values for sodium, for potassium, for chloride and bicarbonate. So one, it helps you for anion gap. Two, it helps you to deal with any electrolyte deficits that you have, which can have long lasting effects or acute effects on the heart and the other systems of the body. So that is the reason why we are more interested in electrolyte anomalies also.
Ma'am, we had another question. How do
Yeah.
ABG results guide is, how do ABG results guide us in managing patients on mechanical
Repeat.
ventilation?
How do
How do
ABG?
ABG results
Yeah.
how
Mechanical
do
ventilation.
ABG results guide us in patients on
Patients in
mechanical
mechanical ventilation.
ventilation?
Mechanical ventilation, what they say is when the person is on mechanical ventilation, you take an ABG, you might have a very high oxygen value. So if you leave that alone, so usually what they say is the person must be fine, and then only you have to collect. That is, the person must be stable. You should be able to collect the blood after that 15 minutes later, and then you have to do an ABG. That is, if he is able to withstand that 15 minutes without a ventilator. But if he is on a ventilator, then the PO2 will anyway be high. So that we will not bother. But we can look at the other acid-base disturbances which are taking place. And we will definitely know the cause. You will also know whether it is a simple acid-base disorder or it is a mixed acid-base disorder. And then you will be able to relate all this. Then you will be able to look at that and say that, okay, is it respiratory or is it metabolic? Is it a combination of the two? What should I include in my treatment to either increase the base, to reduce the acid? What should I do? And then you will look at the, so that is the reason why people even on mechanical ventilation also they look at their ABGs, because constantly what are we worried about? We are worried about if there is a change in the pH, what will happen to the proteins in our body? What will happen to the electrolytes in our body? The damage that it can cause. because finally it is a bunch of macromolecules in the body which are going to be affected with a change in pH. That is why we have to see for any patient who is admitted with ICU or is suffering from some disorder, as we have seen the causes, acute as well as chronic causes, you have to always look at that. The body tries to maintain the pH so that there will be no further complication, so that all the proteins, other macromolecules in your body are able to function well, especially the proteins. And you know, all the enzymes in your body are proteins majorly. And if they are not acting well, then there is no question of ATP. If there is no ATP, there is no question of life. So that is the reason why we have to
Madam,
worry. Yes, sir.
can I tell?
Yes, sir. Please do.
See, suppose if acute respiratory acidosis, then we have to increase the tidal volume, increase the PEEP, increase the 5O2. Suppose if it is chronic, we should be very careful, very slow. So by mechanical ventilator only, we can increase the FiO2. Or otherwise, FiO2 can be increased up to 40% only without mechanical ventilator. So to increase the FiO2 and respiratory rate, tidal volume to regulate, we have to use mechanical ventilator. Just I given an example, acute respiratory acidosis, that is less than 48 hours.
Thank you, sir.
Ma'am, we had another question. Why we use only arterial blood? Why not venous blood used for analysis?
It's a
Can I
very good
repeat, ma'am?
question. Yeah, no, I got it. Very good
Okay,
question.
ma'am.
The reason is that there are many changes in the venous blood, and venous blood, you will have a very high PCO2 normally also, as we all know. So that will not give you the accurately what is actually happening in the arteries. So you'll have a high PCO2, you can have a change in the lactate values also, because these are coming from the tissues. So that is the reason why we don't take a venous blood and we take arterial blood. Sir, do you want to add anything more, sir?
Only arterial blood only should be taken.
Yes, sir. I hope it is clarified, Ajay.
Yes, ma'am. Ma'am, can we end the session?
Yeah, we can end the session.
Yes.
Thank you very much. So thank Ajay, and I thank Clirnet, and I thank Ramanamurthy sir for adding to the proceedings. Thank you very much, sir. It's a pleasure to be learning from you, sir. Thank you, sir.
Thank you very much, ma'am, for such an enlightening and interactive session on ABG interpretation. I also thank all participants for your active involvement and presence. On behalf of GSL Medical College and National Medicos Organization, I express my heartfelt gratitude to our respected speaker and to each one of you who joined us today. We look forward to seeing you all in our upcoming sessions. Thank you, everyone. We are also honored with the presence of Dr. S.V. Ramnamurthy, sir, Professor Emeritus, JSR Medical College, and we also thank Team Clirnet, Mrs. Ritu, Coordinator, and Mrs. Shreyasi, Moderator of this session. Thank you. I'll end up the session with Shanti Mantra. Thank you, ma'am. Thank you, sir.
Thank you, sir. Thank you so much.
सर्वे भवन्तु सुखिनः सर्वे सन्तु निरामया सर्वे भद्राणि पश्यन्तु मा कश्चित् दुःखभाग् भवेत् ॐ शान्ति शान्ति शान्तिः
Thank you, ma'am. Thank you, sir. Thank you, Shreyasi.
Thank you, sir. Thank you so much for giving us the opportunity to host the session. Thank you. Good night to all of you.